Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Casey Patrick, and joining us today are our clinical chief, Nick Smith, and our assistant medical director, Dr. Mike DePasquale. And today we're going to talk about really what's been on our minds for most of 2025, taking up most of our stress, taking up most of our stomach lining, ulcers, sleepless nights, all the above. We've implemented new VL devices here at MCHD. We've been out in the field for a few months now, and things have gone really beyond well following implementation. But like any new device, any new initiative, we've learned some pretty good lessons along the way. So first off, we are going to talk a little device specifics because we did get a specific device and made a transition. So we're utilizing the UE scope. It's a VL standard geometry blade, Mac, somewhat McGrath-like. If you've used a McGrath in the past and you don't know what the UE scope is, it's similar, not exactly. It does have automatic recording capability, like I said. We transitioned from the King Vision channel blade, so that's where we came from. So there we go. Specific devices are out there. No conflict of interest. We just want to let the listeners and speak to the MCHD medics specifically so you can know where we were and where we moved to. Again, our blades are standard geometry Mac style. We do not have hyperangulated blades. We do carry a single small Miller blade for our pediatric population. We also pair this with the Bougie. We believe in the Bougie. We believe that the data supporting Bougie use and first pass success and intubation success, both in the ED and in the EMS setting, is solid. It's not going to turn you into a wizard of intubation, but the intubation success rates comparing Bougie use to non-Bougie use it's too hard to ignore. Our device is malleable, so it is able to be fashioned in a more angulated manner than a standard non-malleable Bougie. It has a copper insert up to 20 centimeters. So those are sort of our specs, I guess would be the best way to describe it. If we're going to use a standard geometry blade and we have a more anterior airway, then our teaching is to just bend that malleable Bougie at a steeper angle, allowing passage. So now that we got the specs out of the way, let's discuss some of our successes, some of our pitfalls. Pitfall is probably not the right word. Just if you take a massive change, like moving from a non-recording King Vision channel blade to a recording VL with a standard geometry, non-channeled blade and a malleable Bougie, that's big for anyone. And when you consider the size of our service, there's going to be things that we learn along the way. So this is not a negative discussion. This is more for the folks out there who are in our service to discuss some of the learning points for them. And also if you're in an EMS system somewhere else and you're thinking about moving to a new VL device or a new airway approach, even if you're not using the same device as here, a lot of these foundations are probably going to pop up as you make your change. So hopefully there's something folks out there listening can learn from us, even if you're not here at MCHD. So Chief Smith, I'm going to take my first swing at you here. Tell the listeners how we rolled this device out. We made the change cold turkey, so we do not have two devices on the truck at once. So rollout was stressful, I believe, even more so than me for you. So how we make the cold turkey swap from the King Vision to the UE scope?
Yeah, the stomach ulcers discussion you talked about was certainly true. Not sure there's much stomach lining left, but this was a big change for us, obviously, with having had the King Vision in our service for really over a decade. It was a device that had a very unique and direct profile for intubating our patients versus moving to the UE scope, which as you mentioned was that traditional Mac geometry. So there was a lot to educate on here, a lot to practice with, a lot to roll out service-wide in general. Choosing the UE scope was something that, as you are well aware of, we've vetted extensively from conference after conference and trade show after trade show, involving our folks from the field in those as well. And so when it came time to rolling it out, here at MCHD, our district chiefs, or essentially our field supervisors, they have a monthly meeting and we elected to employ sort of a train the trainer model first and foremost. So with that, we had the district chiefs and our captains, or essentially our equivalent field training officers, attend that meeting, and we taught them how to use the UE scope, the functionality, how to intubate, and used mannequins, really 3, or in that meeting, 4 different varieties of mannequins for that practice and training. So with that, we had them intubate adult mannequins at a minimum of 25 repetitions. They had a minimum of 2 difficult airway mannequin intubations. So we're lucky enough to have equipment here where we can adjust the tongue sufflation, we can adjust the general airway anatomy with these mannequins to make them more difficult. And we also gave them 2 pediatric mannequin intubations and then 2 infant mannequin intubations. So a lot of reps here in that train the trainer model. And that being a smaller group allowed us more time to really have a hands-on approach with them. And Dr. DePasquale, you were very big and integral in that day, in that rollout, that you sort of spearheaded the PowerPoint, the training, and we got to break up into groups and really hit home those intubations. So from there, we have our quarterly CEs, and the next quarterly CE was when we were rolling that out to the rest of the field staff, which of course, logistically, that becomes difficult to put together, being that we have anywhere between 60 to 70 medics per session per day rolling through. And we had a similar approach with them, where they would do the 25 plus adult intubations, the 2 difficult airway intubations, and the pediatric intubations as well. So with that, we also had a big change in the actual holding of the tube in the Bougie, which, Dr. DePasquale, you're welcome to talk about this too. We switched to what's known as a Kiwi grip or a pistol grip. Mm-hmm. And so it really wasn't just a new device. We had been using Bougies, but this is different. It's a malleable Bougie. It's different in the grip and the approach that they were taking. So lots of things to train on in that CE. And from there, we've talked about this to our folks before this podcast recording, of course, but we really focused on prioritizing, at least for the first approximately 6 months, having our district chiefs, our captains, get the field intubations with the UE scope. Because those are the folks that are going to have to be there on pretty much every intubation that we perform, every DSI. They have to be the subject matter experts, and they need the reps to see and be able to assist and help others. So that's sort of in a nutshell, how we rolled that out here in the service.
We'll come back to some of those differences here in a second, because some of those differences in the devices we've sort of seen in an even more magnified manner watching these videos. And so I'll throw this one at Dr. DePasquale. We now can watch, and we do, review all of our intubations from a clinical services medical director standpoint. So we got all these recorded clips. We're up over 70 intubations now since rollout. So tell the listeners a little bit about the recording aspect of this, the oversight, sort of the education that we've been able to provide in a really focused and precise manner now that we can finally see into that black box, mm-hmm. which is, what did the medic see in the airway?
We get into some gross airways. There's all kinds of stuff in there: food, debris, blood, mucus, emesis. It's gross. And just looking at those videos, I was like, wow, these are dirty, difficult tubes to get in someone's house, which of course we always knew, but now we get to look at, and we get to look at all of them. And honestly, after doing this is, I think this is probably the new standard, right? If your service is going to be doing intubation, I feel like you have to be recording them so that you can continuously do QA on them and make sure that people are getting the feedback that they need. Because what we are doing here is that every single intubation, successful or not, every attempt gets viewed by one of the medical directors, and then within 5 to 7 days gets a full feedback back. We use a messaging service that's service-wide here, like a Zoom, WebEx kind of thing. And so we can directly message people in the service on this app, And within a week of them having their intubation done, they get a abbreviated clip of the intubation, because as I'm sure you can imagine, from when you turn the device on until you turn it off, there's a lot of extra stuff in there getting set up and then afterwards. So we clean up the image. We take all the identifying stuff out of it, so it's just the airway. So these can be shown to more than just the people who did them. We can share them with the service for education. But what we do is we include whoever was on that call, district chief and crew included. We give them their clip, and then we give them pointed feedback on their specific intubation attempt. And I mean, I never had that. I mean, I never got that. I don't get that now in the ER. I mean, I would have loved that. I'd love it now if I could record them in the ER and get, someone more experienced than myself to say, hey, maybe do this, do that. I think it's great. And the feedback from the crews has been excellent. I mean, there have been some that need more feedback than others, and I've gone and, gotten airway diagrams and drawn on them and posted those. And sometimes we'll take the videos and annotate them live and, kind of edit the video and put arrows and pause them and put text in there so that everyone can see what we're all talking about. And I think that that's completely invaluable, especially in EMS where the reps aren't high. So to have someone say, here's how it went and here's how you could do better next time, or here's why it was so excellent, or here's maybe a technique that would make you get it a little sooner next time, I think is super useful for the service. And honestly for us, because it's always been like this, we just didn't have them recorded. Now that we have them recorded, we can see and we can provide the feedback. And, and for us, that has led us to some situations where there are maybe a particular individual is making the same kind of error over and over, and they don't know that because they're just trying to do intubation, and previously we wouldn't have known. But now that we can see a small adjustment can be made and we'll be getting a much better view, we can bring them in and just do some re-education, mess around on the mannequin for 30 minutes, really 30 minutes, give them the little pointer, and then the next couple of videos we see after that are 1,000 times better, and we're getting great views, and the intubation's going much more smoothly, which I can't think of a way you could have done that previously without being able to see these videos. So I'm a big fan, if that wasn't clear.
Well, and that's not hypothetical. So we're not going to name names, obviously, but we have had that medic in the office with a little bit of the shoulder shrug, a little bit of the resistance. Let's watch this on the screen, get some feedback from leadership, from medical direction. The facial features soften a little bit, the eyebrows raise. We go up with hands-on reps. Those intubations go smoother than the one that was recorded. They start to connect the dots. The next one goes smooth as silk. And those are some real high fives. Those are real, that's real buy-in. And I know for the medics that are listening out there, you know who you are that have already been able to receive that education. And for us, it's not about some draconian level of oversight. It's about helping people become successful quicker than they could have and would have before, because we have this information. And I truly believe that this will be standard of care. I put a much harder exclamation point on that. I believe that there are thought leaders and experts in the emergency department setting who already believe this and are already publishing and talking about this. 10 years from now, it will be thought of like waveform capnography, in the sense that how did we not do this forever? And technology is the answer to this one, but I believe it's a no-brainer. Chief Smith?
Yeah, I mean, you just hit on a point there. We don't want to be draconian, and that scene that you described of the medic who comes in and they're maybe a little standoffish. I think nobody likes having, a blown up view of their game day footage up there when they know there's some areas that they can improve. But that's what's been so great about this, is that we get the opportunity to show them this isn't a big brother gotcha moment. This is true real-time education. And how often do you get to take that from any other initiative where you get to sit down and say, hey, let's look at what happened. Let's look at the situation of the scene, how the patient was, and what areas can we look at specifically to help you improve. And that's all it is an educational improvement opportunity. And once they see that, that's to your point of when they start to relax, the shoulders go down, they see it's for improvement. It's for the betterment of themselves and for the patient. And
you help somebody become a better intubator. And there's no more fulfilling high five in my world as a teacher than that. And I mean that from like the bottom of my soul. Like watching folks get better at this in real time and improve their patient care in ways that were impossible 6 months ago. it's just amazing. Now, that said, there have been some trends, and there have been some common themes that we've noticed where service-wide education has been needed. And that's the other wonderful piece of this, is that you can take your specific changes back to your individual medics, but you can also see 7 medics doing the same thing and saying, that's not an individual medic problem, and maybe we didn't educate well in the rollout. And I will take blame for some of those maybe spots where we could have been more definitive and more declarative. And some of them just have been unanticipated and have been maybe device specific a little bit. So rather than walking around in the dark as oversight, as DCS and Department of Clinical Services, we've been able to say, hey, let's re-educate in our next continuing education session. When we put this training out in the field for on-the-road CE, let's make this point really, really hammered home. We've got Cadaver Lab coming up in a couple weeks. Let's throw this into Cadaver Lab. We're going to retrain in the fourth quarter. Let's make sure that we hit these points. The biggest one that I have seen, and I'll let you guys take one, has been the lack of progressive laryngoscopy. In other words, I see the tongue, I see the uvula, I'm going to walk around the corner, there's the epiglottis, let's put the blade in the vallecula and lift. With the channeled King Vision structure as it was, there was really no need for that walk or that progressive approach. You just kind of plunge the blade in, and where it ended up is where it ended up. And then you tracked the bougie and the tube that was already preloaded. So you had no dexterity with where the bougie and the tube was. You just slid it down like a water slide, and you just went down the water slide. Looking at our videos and noticing that was the tact and that was the approach that medics were taking with the blade really highlighted to us that there's a big difference in the mechanics if one is a King Vision user for life versus someone who has direct experience. And it was really interesting watching some of the more experienced medics come through and realizing that they could dust off their old DL mechanics for this, and even their faces lit up. So the definitive piece here is that with the MAC geometry standard UE scope blades, we have to get in the vallecula, and I'm speaking to the MCHD medics now. This should have been a little firmer. Yes, you can use a MAC blade like a Miller, and you can pinch or pick up the epiglottis, but that does you no favors from an angle of bougie passage and from a camera standpoint. So we have to get the blade in the vallecula, and honestly, after CE I've reviewed, we hammered that point home in our last CE during EMS week, and even the few that I've watched since then have done a markedly improved job getting it there. And that brings us to the color of our bougie is white, the malleable bougie is white, and that's created some problems with camera dynamics. So when you guys take the screen washout and sort of blade in the vallecula and talk about how all those things combine to some hurdles that we maybe didn't expect quite as much.
Yeah, sure. I'll take it. So with the screen washout, and specifically for those who aren't familiar with what that looks like, it's called whiteout. So essentially we have the white USB or the universal stylet bougie that when that gets in front of the view of the camera, which is attached to the blade, we have essentially a hyperfixation on that white color that makes the background behind it go dark. And obviously that's not something that's ideal for an airway setting. You're not there to focus on the bougie on its own. You're there to focus on visualizing that glottic opening and passing the bougie through the cords to get the tube through. A big thing that we learned from this is that it sort of goes hand in hand with what you just talked about, where we have the plunge, we're maybe utilizing the MAC blade a little bit like a Miller, where we're directly lifting up the epiglottis, and then we push the bougie down there, and then it goes directly in front of the camera, directly in front of that site, that then causes the rest of the background to go black, and you have that whiteout. And so what we've learned is that when you place the tip of the blade into the vallecula and you lift, you create that distance from where the coude tip is not directly in front of the camera of the blade, creating less, not always perfect, but less whiteout than you would typically see as when you go in with the plunge and the coude tip swipes right in front of it.
Hip, suction, midline, some micro movements. Dr. DePasquale, there's sort of smaller, figuratively and literally, things that we've noticed where folks can improve, and it's not about being perfect. It's just about putting yourself in the best position you can to be successful.
Right. Not everyone needs to have the suction catheter put in when you do the intubation, but some people do. And when do you know that? So what I would say, especially after having done them myself and watching these videos, honestly, if someone's in cardiac arrest and you're going for the tube, put the suction in. They're going to have all kinds of gastric contents in there. You know, valves are opening and things are moving around, and there's always going to be something to suction. And I can't think of when I was a medic, one cardiac arrest we did where we didn't just put the suction in first because you knew it was coming. So for those, I would say go in with the suction because you don't want to get the camera all goobered up, right? Because if you get fluid or blood on the camera, now you've got to come out, you've got to wipe it, you've got to start over all over again. So for those cases, I would. Now, obviously, if the patient is vomiting and you know it's coming, lead with the suction. For someone is more like a COPD or someone that's having respiratory failure who we're doing DSI on, that one you may not need to lead with suction. They haven't been having frothy sputum. The airway's been otherwise clean. So when you go in, you can see. Now, obviously, the suction needs to be ready to go and next to you and on. And if you get in there and you need it, then it's needed. One of the issues that we've seen is that because of the way we're doing the so-called pistol grip or kiwi grip is that the intubator is already holding the ET tube when they go in with the blade, because you're holding the tube in a way that the bougie is sticking out from the tip of the ET tube, and you have the more proximal end of the bougie kind of, instead of it flopping all the way around, you're also holding that end too. If you don't know what I'm talking about, you can look up kiwi or pistol grip. But if you get in there and you need suction, well, you don't have three hands. So someone else, you should pass off the tube to someone else and grab the suction and do it that way, and then, trade back. That's kind of been the big thing we've seen with the suction. It's not also, I will also say, it's not necessary to get the airway pristinely clean. We've seen some people go to town with the suction like it's like they're the cleaning service or something. Like, you just need enough to get the view that you need and make sure that the blade's not going to get all messed up because it's completely overflowing with gastric contents. The other thing is midline, right? When you're going in with the blade, you're doing a right to left sweep with the tongue. And again, for anyone non-MCHD who's listening who, you guys are still doing DL or you've been using MAX, this is just a MAC blade. So you're going in from right to left, you're lifting the tongue and moving it out of the way. We're doing progressive intubation, which means we're seeing the heart into the soft palate, we're seeing the uvula, and we're going beyond that so that we can get to molecular space. But we want to make sure we are staying midline. We're trying to align the three major airway axes so that they're as aligned as possible so that you have a straight shot right into the airway. So when you put the bougie in, it just goes straight in. And you can look up airway axes too. There's a ton of stuff on this. If you come off of midline or you've come sideways or the main view of the cords falls out of view, it's going to be much more difficult to try and pass a straight line bougie 30 degrees off to the side because you were pointing the wrong way. And these are small movements. The other thing we see a lot of big movements when trying to make adjustments. And this is just a experience thing. It just takes reps to get good at this. It's all just kind of hand-eye coordination now more using this camera than when you were actually looking down somebody's throat because you could kind of correlate. Now there's not a lot of correlation. At least we're looking in the same general area. I know when I trained, my head was about 50 degrees in the other direction looking at the screen. I couldn't even see the patient I was trying to intubate when we were doing it. But when you get in there, you want to make sure you're staying midline, and that if you need to make adjustments, you make very small adjustments, because you're dealing with a couple centimeter area there in the back of the throat in the glottic opening. You don't want to make big sweeping changes because then you're going to get off axis and you're going to have to try and recover from that big change that you just made.
So all of these road bumps that we've hit, it sounds like gloom and doom, but it 1,000% is not. We have performed exceedingly well despite rolling out a new device with a new approach with almost 180 degree difference in the mechanics and the tack that you take to get to the airway. So what have our initial rough numbers looked like since rollout for Dr. DePasquale? And then we'll let Chief Smith wrap up with what are our plans moving forward, how are we going to sand off some of these rough edges. So where are we today numbers-wise?
So roughly speaking, looking at the intubations that we've done with the UE scope, now that we have this data, we're tracking around 80 to 85% in terms of first pass success. Now, of course, that takes into account some missing data. Not every file gets uploaded, but just kind of looking at the rough numbers and looking at those videos, that's about where we are.
And for those wondering about file upload, we are well over 90% of those at this point. We're working a lot of kinks out when it comes to the back end. Who uploads those files? How do they get reviewed? How does that data get tracked? So nobody's trying to be evasive here. We're just, as Department of Clinical Services, not quite ready to have good polished data yet because it's been a massive rollout with tons of work. I feel like 80 to 85% is absolutely stellar for a new device across 350 plus clinicians out there with a brand new device. I'll stand beside that 7 days a week. Our goal is to get to 90, and we also know that there are caveats within first pass success, and that if you're in the airway for 4 minutes to get it through and the patient Brady's down in arrest, your first pass success is useless. So I'm very well aware that there's nuance in that statement, but it is the big number that we track. We also track DASH and DASH 1A, and we want to make sure that they're not getting hypotensive and hypoxic during the attempts. And if it's a 2-attempt intubation and the patient is stable throughout, that is a win for our service. So we could talk about that for an entire second episode, but we're in a really good spot. Moral of the story, our success and our intubation prowess has not suffered some fall off a cliff, and we are going to end up better than where we were before because of that education piece. So that's really the part that I'm taking to heart as a medical director. I know everybody at this table is as well. Getting close to time, Chief Smith, where are we going in the future?
Yeah, so I think it really comes down to 3 words, which is train, review, train. We are so fortunate to have a lot of educational resources available to us at MCHD. You mentioned earlier our cadaver lab that at the time of this recording is coming up in a couple weeks. We'll be utilizing our UE scopes during the cadaver lab to have our folks get reps on real human and anatomical airways. We have our on-the-road quarterly CE that we collaborate with our district chiefs on, where our folks rotate through the regional stations and perform scenarios. The UE scopes, spoiler alert for the next on-the-road CE, will also be included in that.
Shocker.
Yeah. And then as we go towards the end of the year, our 4th quarter CE will also be centered around airway training. Again, spoiler alert for the medics out there. Hopefully this isn't too big of a surprise, but that will be focused on our airway training and the lessons that we've learned and that we get to share and that we get to refine. Because as much as we've talked about how these airway videos are, looking at the intubator, the laryngoscopist, it's looking at our field crew, it also allows us to look back, as you said, in a systems perspective. And it's us looking in the mirror too and saying, this is how we taught this, or this is how we took this approach. You know what, that's not working to how we expected, or maybe we need to improve this. And so bringing that together, it really has been a good reflection piece for us to learn how to refine this training. So going forward, it's train, review, train, and sending consistent feedback to our providers through medical direction, I think has been a real game changer.
And if you're listening out there and you're like, man, this is just too much airway training, airway, then I don't know what to tell you.
Good.
If my job was paying me for advanced airway training over and over and over again, I'd be like a kid in the bounce house in the ball pit. Like, that's what we came to do this job for. Mm-hmm. So for me, any other training, nothing is as exciting for me as airway training. And then when you throw in a new device with recording VL, like, I don't know, I got a screen on my own to use in my own practice, and so I've intubated a few patients with this exact setup. A couple of them went really well. One of them, I don't know that I want to show anyone. It was a little more of a struggle. I was successful in all 3. Let's be honest. I'm going to get that out there. A couple of them would have been really nice on YouTube. The third one is I I needed some remediation and some feedback for sure. But in the end, I was excited as a kid in the candy store getting to use a new device and in the end, providing better patient care. I wasn't looking off at some screen. I wasn't squinting, looking down their airway axis with my actual own old eyes. I was looking at a really high resolution screen and using a really high quality setup. So that's a good spot to wrap us up. Thank y'all for the discussion today. For the MCHD listeners out there, if you have specific questions, reach out to us at DCS. For everyone else, if you have questions or ideas or concerns, podcast at mchd-tx.org. Wherever you listen to podcasts, or if you're watching us on YouTube, leave us a like, leave us a review, subscribe. We appreciate it. Thank you all for joining us. We'll be back again with a new episode soon.